Hi, my name is Gary Clifford. I'm the Chair of Biomedical Informatics at Emory University, and I'm also a Professor of Biomedical Engineering in the Georgia Tech and Emory Joint BME program. And today I'm going to talk to you about our South Hub Spoke, which was funded by the National Science Foundation. And I'm a PI on this with Dr. Herman Taylor at Morehouse School of Medicine, where I'm also an adjunct. We called this platform Moyo after the Kiswahili word for heart, because primarily this is focused on the cardiovascular disease initially, although it is a generalized platform that can go way beyond cardiovascular disease. This National Science Foundation funding award is co-PI'd by Dr. Herman Taylor over at Morehouse School of Medicine, where I also have an adjunct position. And of course involves a whole array of universities, including University of Arkansas in Little Rock, West Virginia University, University of Virginia, and UT Dallas, as well as Georgia Tech. So the background is that cardiovascular disease is still the leading cause of death, both globally and nationally within the United States. About 600,000 people die from cardiovascular disease every year. And it costs over $207 billion every year from cost of services, medications, and lost productivity. And you can see the evolution of this over the last 30 or 40 years on the right-hand side here. And in particular, we see that the burden of CVD is disproportionately on the population residing in the southeast of the United States, which we often refer to as the stroke belt because of this. But what's really interesting is how this disproportionately affects the African-American population in the United States. If we look at the density of the African-American population within the United States, we see that the predominant concentration is also in the southeast. And therefore, there's a disproportionate burden of CVD upon this population. As part of this, this spoke, we wanted to design something that wasn't just targeted at managing the chronic aspects of the disease, but catching it early and having a much greater effect therefore. So in other words, we were looking at how do behaviors, habits connected with exercise and diet, for example, and interactions with the environment are connected with long-term cardiovascular disease, and how can we make individuals aware of these choices or lack of choices and how they can start to address these in their everyday life. So we were looking at how the resources around somebody, the environment, the exposome, if you like, can actually influence your particular, your ability to access the resources around you to affect this. So quite interestingly, if you look at other spatial correlations, you see that heart disease is also spatially correlated with your access to food. So we call this food deserts in essence, in that when there is a lack of access to good quality food, that is not fast food, but fresh fruits and vegetables and healthy food options, then that is highly correlated also with the burden of CVD within the United States. So if we toggle between those two, again, you can see, again, the Southeast is particularly affected by heart disease and also by a dearth of accessibility to healthy food. Of course, it goes beyond this because also you need the economic resources. And if you look at socioeconomic variables, they're also spatially correlated here. So another issue that we wanted to address was this lack of information outside the electronic healthcare records. So we have a lot of data in electronic healthcare records, although it's sparser than you would imagine. But there is also a lot of information that happens outside of the hospital that we don't capture, particularly in the long buildup. And often in healthcare, we only capture this information when a problem becomes acute all through the chronic phase. And this is essentially too late. And our question was, how do we capture this data in the lead up to this? And of course, you start thinking about how do you capture data from different populations, but there's a strong lack of trust in institutions collecting data historically from different subpopulations around the United States. We're all aware of Tuskegee, I think, and the horrors that came from that in the last century. But the distrust in research participation and engaging with providers to provide data goes way beyond that historical atrocity. And in fact, quite recently, surveys have shown that the pandemic has exacerbated these issues, and we see that African-American adults have less positive views of medical scientists than other races in the United States. And this means that there's a lack of, this means that this population that has a disproportionate burden of healthcare and healthcare access and of healthcare problems, particularly in cardiovascular disease, also is less likely to trust the information to help them address these issues. So what we wanted to do was look at how we would address this through a user-centered design process and community-based participatory research. So before we built any technology around collecting data, the first thing that we did was to start engaging with the populations that we were interested in working with and co-designing a solution for this with. And so we initially worked with Rodney Sampson at Opportunity Hub, and we went through a series of health tech weekends. This is Rodney here giving part of the pitch to an audience of largely African-American youth from around Atlanta that had come to help us co-design some technology around providing insights into cardiovascular disease. And we did a series of these workshops where we went through a standardized process for co-design to try and come up with ideas of what would be exciting and address issues that were of concern to the population that we were trying to target for healthcare interventions here. And at the end of it, at the end of this long weekend, and there were a series of 4 of these weekends, the groups would get up and pitch their different solutions to the problem. And we took note of all these different solutions, and we took the ideas back, and then we started a co-design. One of the other keys is that we also hired members of this community, particularly through the Code Start program with Opportunity Hub. These are African Americans who have historically had limited access to education, and they were retrained in how to code through this Code Start program, and then they interned with us, and then some of them eventually became full-time employees with us to work on this particular design. And one of them has actually been working with us for almost 4 years now, and it's become a long-term employee within the department because of this particular process. So it's a real success story in terms of integrating with the community that we wanted to build the solution with. And what we did was we came up with this HIPAA-compliant cloud infrastructure with a series of APIs and a generic app system that would allow us to collect data related to various aspects of behavior that were key to individuals' health. And this ranged from wearables and integration with electronic healthcare records through standardized Smart on Fire APIs, through to social networking activity and self-reported clinical scales, physiology, and diet, amongst other things. And I'll talk about a little some of these as we go through. But we also did some interesting data analytics to improve the resolution of the data that we could collect as well. So one of the things that we did was to build a food desert mapping system through a crowdsourcing process. What we did was we took Yelp data to pull all the retailers within the greater Atlanta metro area. And then we ranked them together with data from Google Maps to identify how far each of these were from an individual point on any given map, so that we could work out distance via different forms of transportation. Then we took the most important retailers, the most frequently identified retailers, and all the census tract information that was most importantly related to food desert information. And we also then used Amazon Mechanical Turk to extract out what type of, and label what type of stores were there on Yelp and Google Maps, the availability of food items and the quality of those food items. So whether they were fresh fruit and vegetables, whether they were processed food, whether they were high in fat, whether they were high in sugar, this kind of thing. And then we built a machine learning model to classify these features and identify the level of food desert in any given location. So now we have a system with an API that would take these census tracts around the Metro Atlanta area and allow us to very, very finely tune what the level of food quality would be in any given area. And here you can see it color coded. Basically, the greener you are in any particular location, the better the food availability. And then the darker the line, the worse the food availability. And this is just a journey from Emory to Georgia Tech, for example. And you can see the changes in quality of the food within that journey. And the point behind this is now you have a system that allows you to plan a journey, not based on the quickest journey time or the least amount of traffic, but also on the quality of food that you might encounter on the journey as you go through this. The idea behind that being that availability of food is absolutely key to the quality of food that you eat, quite obviously. So you can see, these transitions. This is right near one of our offices, and you can see that where there's a lot of food within clustered around Emory, there's some good food choices, and then as soon as you get out of that region, it drops very rapidly. So we built this app that allowed us to pull through geolocation data, things like weather and pollution as well in the environment. And this would give us a level, anybody could poll at any given moment what the level of food desertness was in a particular location, what the level of pollution was and weather. And you could build up a map, a spatial temporal map over time, what your exposures are to these particular zeitgebers, essentially. And so that tells you how well, or rather what types of things are influencing your behavior. And we know that pollution is also coupled to things like glycemic control. So all of these exposures are absolutely key in determining the environmental factors that go into your long-term health. We also looked at a way of self-reporting on food, so people could take pictures of food and document this. So later on, we can build an image analysis algorithm to allow us to automatically classify the quality of food. We also included several clinical scales, so things like the PHQ-9, which is a standardized mental health scale, and the KCCQ, which is standardized cardiovascular scale, amongst other things. So these have very strong correlations to outcomes and interventions. So being able to report on these gives us a semi-objective label on which to analyze our features and regress our features. We also created some simple mood reporting scales. This is just a smiley face that you can swipe up or down to make you happy or sad. And this was based on feedback from the communities to reduce the burden of data entry. We also looked at social networking data because the social networking, your social system that you are located within is a strong indicator of your mental health, which of course is strongly coupled to your physical health. And so the mental illness, so the social network itself is dynamically changing based upon how happy or sad you are and how much you are willing to engage with the community. Of course, there are biases in the way that this is analyzed, and also there are issues around the sharing of data. So what we did was we built a system that analyzed the social data on a completely anonymous basis. So we don't know who you're calling. We just know the size of your social network and how often you interact with them. And then we looked at content of text messages in a completely de-identified way as well, to do some natural language processing to build racially unbiased estimates of health literacy and of numerical literacy or financial literacy, which are also key to ability to maintain physical and mental health. We also provided a way of capturing physiology from instruments. You might instantly think, oh, we would build a Bluetooth API to integrate instruments, but actually it turns out that the lift of trying to integrate every single device that anybody could possibly use in an app is enormous. And so the approach we decided to take was to capture information through a photograph. So somebody would take a photograph of, for instance, this is a picture of the blood pressure unit that you would find in CVS. And then what we would do is process this information, and we've built a system that allows us to capture this blood pressure information and digitize it using a deep neural network to estimate the blood pressure or essentially do optical character recognition from these LCD and LED displays. And we've shown that we can do that within an error of just 3 millimeters of mercury, which is within the FDA limits for acceptability. And then perhaps most importantly of all of this, we provide absolute full control to the user so they can turn any of the pieces of information on or off. So if they don't wish us to look at what physical activity is going on at any given time, they can turn the accelerometer off. If they don't want us to look at location data because they don't want anybody to know why they're in a particular location at a given time, they can turn that off. They can turn off social networking data collection if they don't want us to know or they don't trust us to look at who they're communicating with, even though we completely de-identify that social network before any data is uploaded. And you can also turn off the types of establishments that people are going in and out of, because we also use the Google Map API to log what types of restaurants you're going in and out of, in case that was too revealing for them. And of course, they can also log out from the application and just keep a local copy instead. So to sum up, what we've done is we've inclusively co-designed through community-based participatory research and user-centered design this very generalized platform for collecting information on users' behavior connected with health in a very generic sense. There's a large amount of data transparency in this. The user is in control. It's integrated with electronic health data, wearable data. It provides your ability to collect ecological momentary analysis. That is, what is somebody doing in any given moment. It collects environmental data. And most importantly, it's community owned. In other words, we have a system that is open source. It's completely devoid of licenses except for an open access, open source license under a BSD 3 license. And so nobody has to pay any licensing fees to use this, and they can build anything they want on top of it. In particular, they can build businesses on top of it. So if somebody wants to create an application that has some business financial reward system within it and some profit motive, then they're free to do that. But it also means that researchers can use it for free on top of that. So the idea is that it enables replication of the system and usage of the system way beyond research. Our impacts have been multiple internships from the communities of interest. One of the interns completed their degree whilst working with us and has been now employed with us for 4 years. So we think of him as one of our Moyo graduates. We've deployed this within the UT Southwestern healthcare system. We've used it at Emory and VA for CHF monitoring. And actually, as part of this, we've shown that we can now predict decompensation events in heart failure. That's one of our real impacts on this. And now, as a long-term sustainability option, we're now adopting it within the Georgia CTSA for broader use. So our next steps are adaptation of this to address maternal mortality and maternal child health in the Southeast. This is one of our biggest problems in the Southeast, and particularly in Georgia. I think we're second from the bottom in the nation in terms of maternal mortality. We're also going to broadly disseminate the software for free. There's this integration with the CTSA to address rural health issues. And we're expanding training programs, potentially with incarcerated populations in collaboration with Georgia State and the University of Georgia. And that's it. Thank you very much.